Hello, my name is Lori Okamizo. I'm a physical therapist and a recent graduate of University of Utah's Neurologic Physical Therapy Residency Program. During my residency, I worked with Heather Hayes to conduct a case study, and I'm here to present that information to you today. So the title of our case is called Combined Intervention of Electrical Sensory Stimulation and Mask Practice in a Patient with Chronic Stroke. Approximately 50% of stroke survivors experience sensory loss in their affected upper extremity. These sensory impairments negatively affect function and activity participation, even if the patient does not have a concomitant hemiparesis in that side. On the flip side, sensory stimulation has been shown to increase corticomotor excitability as well as neuroplasticity, which can translate to improved outcomes and function. So the goal of this study was to describe the intervention and results after use of an extended sensory stimulation program combined with a mass task-specific practice in a person with chronic stroke and unilateral sensory loss. The subject is a 70-year-old male who suffered a right thalamic hemorrhagic stroke 2 years prior to this intervention. He had absent light touch and proprioception in his left arm, but did have intact vibration sense in his left arm. He had a Fugl-Meyer upper extremity score of 54 out of 66 and did have left hemiplegic spasticity. He was status post a left triceps, biceps, forearm, gastroc soleus, and posterior tibialis neurectomy, and was also participating in a spinal cord stimulation trial with Boston Scientific Device, and also had undergone some Botox injections to help try to manage that spasticity since his stroke. Thankfully, this subject had great social support and was able to return to work full-time with the assistance of a full-time aide. So our intervention was twofold. We had on one side the extended sensory stimulation, which I've listed here. We named it extended sensory stimulation because we left it on for 3 to 5 hours a day. We had the 4 motor points at the wrist extensors, finger extensors, triceps, and anterior deltoid at a sensory or subsensory level of stimulation. We combined that with the masked task-specific practice, where the patient was practicing his own self-identified goals. So he had set some goals for himself that he wanted to achieve, and for 6 hours a day for 2 weeks, he practiced those activities. So here you can see him practicing grasping and reaching for a cup. He also practiced walking, performing a car transfer, and buttoning the cuff on his opposite arm. All of these activities were done with the extended sensory stimulation on. Our outcomes were assessed at day 1 and day 10. We primarily used the Canadian Occupational Performance Measure, or the COPM, which is basically the patient's own self-identified goals, and he ranks them on a scale from 1 to 10 in terms of how well he thinks he's performing that activity and how satisfied he is with that performance. So a score of 1 is that he's not satisfied, or he thinks that he's not performing that activity well. And then a score of 10 would be the opposite of he's very satisfied and thinks he's doing very well performing that task. We also use the Wolf Motor Function Test, which is where the patient is timed completing simple and complex tasks, and we take the average time of those to kind of sum up overall upper extremity function. So obviously for that one, if he's able to perform a task quicker, it's better. So fewer seconds or lower time is better for the Wolf Motor Function Test. And ultimately, we wanted to determine if we could meet the minimally clinically important difference for these outcomes after our intervention. So we have our results here. On the left-hand side, we have our COPM performance rating and his self-identified goals, the COPM satisfaction rating and his self-identified goals, and the Wolf Motor Function Test measured in seconds. Here are his, for the COPM, here are his own ratings. He rated himself. And on the right side, you can see that with the red arrow, I've indicated the measures in which the subject met the MCID for that measure. So you can see he felt that he made a clinically important change in all of his goals. So holding a plate or a cup in his left arm, while walking using a cane, performing a car transfer to a sports car, and buttoning a cuff on his right sleeve. So he thought that he made improvements in all three of those performances. Oops. He also was satisfied. He met the MCID for satisfaction in his car transfer to a sports car. And with the Wolf Motor Function Test, I've listed here the MCD and the MCID. The research has indicated that it's beneficial to look at both of those to determine what is a clinically important change. And because his pre-intervention score was somewhat low, we decided to go with the MCID of 1.5 to 2 seconds, in which case he also made a clinically important change or improvement in his overall upper extremity function, which was awesome. In conclusion, extended sensory stimulation is a feasible supplement to a conventional physical therapy regimen. And even chronic stroke survivors with unilateral sensory loss can continue to improve their participation and activity levels using an intervention of extended sensory stimulation with mass practice. All right, and that's all I got. Here's our references. Thank you so much for listening. Don't hesitate to reach out to Heather Hayes through the Stroke SIG if you have any questions about any of this presentation. Thank you so much. Have a great day.